Okay, so starting out, intrarenal 3. So went through intrarenal 2. We're going on to intrarenal 3. Let's get moving. So the objectives for this intrarenal 3 are to talk about vascular compromise, acute renal failure, chronic renal failure, and renal cell carcinoma. Sorry, there we go. That's a little bit better. Lots to learn in renal in a very short amount of time, so just bear with me. We will tie all this stuff up in a nice, neat bow as we move forward with these lectures and with the review. All right, so vascular compromise. So nearly all diseases affecting the kidney involve renal blood supply or the renal blood vessels. So just keep this in mind that vascular supply obviously is going to provide the flow of oxygen and nutrients. It's also going to provide the flow of solute both in and out of the kidney. So that's how the kidney utilizes its filtering ability. So renal vascular compromise. So systemic vascular diseases will affect the renal vessels, right? That makes sense. So if you have some sort of stenosis, you have some sort of atherosclerosis, you're going to have problems with your kidneys as well. So what we're going to go over here is nephrosclerosis, hypertension, renal artery stenosis, and thrombosis, as well as embolism. So what is nephrosclerosis? So you can pretty much dissect that term. Nephrosclerosis is just sclerosis of the nephron, all right? So it's associated with sclerosis of the renal arterioles and the small arteries, all right? So causing focal ischemia of the parenchyma, right? So you've got small little portions of that kidney that are not getting enough blood flow, therefore they're not getting enough oxygen, nutrients, they're not able to get rid of waste. That causes cell death, okay? Most common process is atherosclerosis. So you've got these plaques, they're building on the vessel, they're constricting the vessel, they're making the vessel less able to accommodate any change in volume, right, from going smaller to bigger, so they're not as adaptive at changing their girth, and so they're rigid, and the vessels are rigid, and the vessels are also lined with plaque, okay? So primarily this is related to poorly controlled hypertension, and that's really why we want to control hypertension in basically all patients, but definitely in patients who have some sort of renal compromise or who already have an atherosclerotic process at work. So basically an easy take home here is as your age increases, your risk increases. So look, by age 40, about 10% will have it, 60, 20%, and 80, 30%. So they're multiples of 2, right? Every 20 years, you have a 10% increase. So there's a 2-to-1 ratio as far as the increase in age with the percentage increase. All right, so what is nephrosclerosis? Well, it's difficult to say, first of all. Secondly, it's caused by systemic hypertension. The capillaries basically are damaged by that hydrostatic pressure. So you've got this big pressure in these tiny little vessels and you're blowing them out. It increases the pressure in the glomeruli, causing one of the two things below to happen. So you can have benign sclerosis, meaning you just damage the vessels, but pretty much function okay. And then you can have malignant sclerosis, which is not going to respond very well to treatment. All right, so what's benign sclerosis? So this is thickening of the glomerular afferent arteriole, right? So here's obviously the afferent arteriole. This is why we belabored those drawing videos. I want you guys to have a really good idea of anatomy so that you know what you're talking about, you know how to think through questions. Okay, so you've got this thickening here. Why? Because you have a high pressure going into this system. You have a lot of pressure pushing into this glomerulus, which can only accept so much flow. And so as that happens, you can think that this afferent arteriole is going to enlarge in size. All right, so you may have a mild to moderate increase in your creatinine You may also have some microscopic hematuria. So think of that, you're just pushing these blood cells through that glomerulus. As your glomerulus becomes damaged, you may not be able to get rid of as much creatinine, or the pressure is so high that you're just pushing more creatinine out, right? So creatinine is an exclusive waste product. So in this respect, we're able to get rid of it, but we're having heightened levels in our blood also. So even though we're getting rid of some through the urinary system, we're not getting rid of enough. So as time goes on, we slowly build our creatinine level in the bloodstream. Microscopic hematuria, right? That makes sense. So if you're putting a lot of pressure through here, the goal of this glomerulus is to not let any blood cells go through here. But if the glomerulus over time becomes damaged and you have this high pressure, you can think of a few of these red blood cells squeaking out. Now, this is not like your processes where the glomerulus is completely damaged. That's going to be gross hematuria, right? So what's the difference between microscopic and gross? Gross, you can see it, right? That's totally gross. When it's microscopic, that means your urine still looks yellow, but when somebody goes to the microscope and looks at it, they can see these blood cells in there. You may also have a mild proteinuria, right? So this is your trace 1+ protein in the urine, but the bad part is this can lead to end-stage renal disease, okay? So that's what we're really trying to prevent here. What is malignant nephrosclerosis? If you can say that 10 times fast, you are a better person than I. So this can develop in patients with long-standing hypertension, underdiagnosed or undiagnosed hypertension, and it is characterized by a rapid, here's the key word here, rapid decrease in renal function. So the hypertension is due to intrarenal vascular injury, right? So this patient has hypertension for a long time. That hypertension has slowly beat up their kidney. Finally, they have this kind of culminating event where the kidney's beat up so bad that it's not able to control the pressure. And so now the kidney then gets damaged, and that's going to increase their blood pressure a lot, right? Because the blood is filtered through the kidney. So now that filter is clogged. Think of it as trying to push water or blood or whatever you want to call it through a filter that's clogged. And so that's why you get this big back pressure, all right? So what are some risk factors for hypertensive nephrosclerosis causing end-stage renal disease? So the risk factors are people, right? People of the age of 45 to 65. So that's kind of our demographic group that's going to progress, right? And as you get older, your risk is going to increase. African Americans, for whatever reason, tend to be plagued by some of these kidney diseases, and so they are at greater risk for this. That's why we really want to control their blood pressure, okay? Habits can contribute, right? Smoking damages the tiny little blood vessels. Nicotine can be hard on the tissues, and so smoking can cause an increase in risk factor, okay? High cholesterol, that's a risk factor. Why? Because they're going to have atherosclerosis. Okay, so if somebody has a bunch of plaques sticking on their blood vessels, well, they're more likely to have hypertensive nephrosclerosis. Oh, I said it right. So the longer you have hypertension, right, duration of hypertension, the more likely you are to blow out your kidneys, okay? And definitely if you have some pre-existing renal injury, that's going to predispose you to damaging your kidneys completely, right? So what is end-stage renal disease? Well, that's the last. That means that your kidneys really aren't functioning and there's no return. All right, so clinically, how do we look at these? Well, we're going to see uncontrolled or poorly controlled hypertension. They may have associated complaints, right? What are the complaints with hypertension? Well, they're pretty vague in reality, but it might be headache, right? It might be chest pain. It might be dyspnea on exertion. It might be dizziness. It might be hematuria, right? So there's a whole bunch of different things that we can say are clinically related to hypertension. So just kind of keep that in mind, all right? Progressive decrease in GFR with symptoms of uremia, okay? So what are uremia symptoms? Well, uremia is profound azothemia that now causes symptoms, okay? So azothemia is buildup of nitrogenous waste products like BUN. That's fine as long as it doesn't cause problems. I mean, obviously we want to treat it, but we're not going to admit this patient and go crazy. We're just going to try to reverse the damage. Once they become uremic, you have end-stage problems. They are encephalopathic because the meninges are inflamed from the uremia. They might have pericarditis because the pericardium is very sensitive to changes in the nitrogenous waste products, and they're inflammatory to the pericardium. They may have coagulation disorder. They may have abnormal bleeding. They could be bleeding out of their gums. They could have a thrombosis because that clotting cascade is totally out of whack. So uremia, I know we've belabored this, and I don't care. The one thing is that you students will know the difference between azothemia and uremia, which most providers don't have a clue. So let's just beat this into your brain. Uremia is symptomatic azothemia. All right. So what does J&C care about? Well, who is J&C? If you don't know that, you better look it up. Okay, so basically the Joint Commission gets together, all these talking heads decide, what are we going to do about this? What are we going to do about nephrosclerosis? So I don't know. What does Fauci think? Okay, so what you're going to do is you're going to identify cardiovascular risk factors, okay? Because that's going to predispose people to nephrosclerosis. Then we want to find out why. Why is their blood pressure elevated? Is it benign? Is there a renal artery stenosis? Is there something bad hiding behind the sheets? We need to find out. Okay. And then we're going to evaluate for evidence of end organ damage. So what the heck does that mean? Well, that means you want to check the kidneys. You need to check the heart. You need to check the liver. You need to check all the end organs that we can check with blood work and maybe some imaging to evaluate how bad these patients are. All right, so what are we going to do with studies here? Well, we can do an ultrasound, right? The ultrasound might lead us to see some damage of that kidney or some sort of change in the kidney. Definitely we're going to check a CBC because we want to look at their hematocrit, right? We want to make sure that they don't have any anemia. We want to make sure that there's no infectious process. We want to see what their platelet count looks like. The CMP is going to be the money shot, right? So we need to check the BUN. We need to check the creatinine. Are they exchanging well with their potassium? Is their calcium out of whack? Is their glucose out of whack? Why do we care about glucose? Because we want to evaluate for diabetes, right? That's a risk factor. Lipid panel, basically we want to see where their lipids are at. Are they atherosclerotic? Are they a vasculopath, right? What's a vasculopath? Well, it's somebody who, this is kind of a term that we use loosely. It's not well defined. You're not going to find any literature on it. It's just like a term that I like to use to say, hey, this person can throw clots. This person is at high risk for stroke. This person is what they call a vasculopath because they have high lipids. They are, they have a lot of gosh, I'm bad at that word. Atherosclerosis, okay? In the urine, we're going to do a general urinalysis, right? Are they spilling protein? What is the microscopic What do the lab rats say about the microscopic appearance of the urine? Is there red cells there? Is there some sort of infectious process going on? Obviously, we want to do an albumin to creatinine ratio, okay? That's done on the urine, and it's done with a 24-hour urine. So we want to see for how much albumin are they spilling out of that kidneys versus how much creatinine are they able to metabolize and get out of the body. All right, so what's the goal? Well, the goal is to treat this, right? We want to treat their hypertension. So treat hypertension to avoid progressive renal failure. We want to treat these patients down to a level of less than 130/80. This is a little bit more aggressive than general blood pressure control. Generally, I like to keep my elderly folks around 140/90 because I don't want them to tank on me or have a syncopal episode or have some sort of ischemia to their brain because they can't control their pressure. But with these patients, you want to keep them a little lower. So look at that treatment goal, 130/80. You also want to begin an ACE inhibitor, an ARB, all right? RAS, right? You guys love the RAS. This system is going to plague you, so you better just break down and learn it. You need to know this backwards, forwards, sideways, and any other way that you can slice this thing because it will help you out. All right, renal artery stenosis. So we're moving on to renal artery stenosis. So what the heck is renal artery stenosis? Well, it's exactly what it says. Your renal artery is stenotic, okay? The renal artery stenosis means that the renal artery is not as wide as it should be. So the blood flow in is augmented and it is artificially decreased. I just threw my mouse across the room. All right, so let's talk about renal artery stenosis. So let's just say this is the take home. Here's the renal artery, here's a renal stenotic artery, okay? Do the math. It screws things up. All right, so it is potentially curable with surgery, so we need to know that because we want to identify this. These are basically people that they're this healthy young person and they come into the clinic and you're like, I cannot control this pressure. I have tried multiple different drug regimens. This guy's pressure is off the chart. Well, it's because they have this stenotic little artery and everything then is backing up from that point. So you've got a problem with your plumbing and you need to get a hold of the plumber. Okay, the plumber are your urologists. Okay, they're the plumbers. All right, so we recognize that there's a cause for renal arteries. We recognize that chronic renal insufficiency caused by renal artery stenosis can contribute to end-stage renal disease. Duh, right? You're not getting enough blood flow to the renal system or the kidneys, either one or both. And what's causing that then is going to be ischemia, right? So you have this low grade to high grade ischemia where you don't get enough oxygen, nutrients to the tissue. And what happens? Well, the tissue starts to be either non-functional or starts to atrophy and necrose or die. What also contributes to this? Oh my gosh, the thing we just learned about. Atherosclerosis. I can say that now. Accounts for 2/3 of these cases, right? So you can say, oh, actually, this person doesn't have a congenital problem. Just over time, they've built up all this atherosclerosis, and now they've got a stenotic artery, right? 1/3 of these cases are bilateral, right? This atherosclerotic process of the renal artery stenosis is common in the older population. Why? Because they're older. They've had more time to develop plaques on their arteries. 50% of cases on average in 5 years will be 100% occluded. So we need to identify these patients because if not, they're in deep, doo-doo. All right. So renal artery stenosis, just like it sounds. What happens with renal artery stenosis is, like I said, I intuitively think of it as a backup, right? So you've got pressure in the afferent arteriole that needs to go into the kidney, but you get a backup. Well, part of that is true. It's an easy way to think of it, but what we also have to remember is we've got this juxtaglomerular complex here, and it's assessing the renal tubule kind of cuts through there, right? And it's assessing flow. So if there's a adequate amount of flow, life is good. It doesn't trigger the RAS. But if there's a low amount of flow, then guess what? Bam, you're going to activate the RAS. And that's going to increase aldosterone into the circulation, which is going to increase the absorption of sodium. Water follows sodium, and bam, your blood pressure goes up, right? So this is the most common cause of secondary hypertension, right? So we always talk about primary hypertension, but secondary hypertension is caused by initiation of the RAS due to renal artery stenosis from atherosclerotic processes. All right, RAS. So y'all know the RAS. You better. All right, so renal artery stenosis, clinically, what are some of the features? Well, hypertension, decreased renal function. They may have an abdominal bruit if you're lucky and it's in a very late stage, and they might have some peripheral edema. So let's go through those. So hypertension. Look for sudden onset of hypertension in a patient without a family history, okay? If they have a family history, then they may have a stenotic artery caused by a congenital problem. But if they don't have a family history, then we're really thinking about a sclerotic process that's causing the severe onset of hypertension that's not treatable, right? Malignant hypertension, you guys should have learned that in cardiology. So malignant hypertension is hypertension that's not responding appropriately to medications. If that occurs, we need to treat that. All right, and it may be refractive to medication, right? That's the whole definition of malignant hypertension. Okay, they may have a decreased renal function, decreased GFR, right? Their BUN creatinine ratio may be elevated. They may have symptoms such as uremia, which we all know what uremia is. Yay! Their creatinine may increase greater than 15%, and this is in a short amount of time. This is strongly suggestive of renal artery stenosis. So say that week after week after week, we're seeing this progressive 15% decline in GFR, and we're still treating the hypertension, and that's even tough to treat. It's like there is something weird going on here. So in this case, we want to talk to both the plumbers and the electricians. So we're going to refer them to urology and to nephrology so they can both kind of lay eyes on this patient, but we want to suspect this because we can start some treatment earlier. So we also want to do a good abdominal exam. We can look for a renal bruit. So you basically auscultate right over the flanks, okay, in that CVA area, and you're using your bell to listen for this. And that sound is it's high flow blood that hits that stenotic region. And so you hear it kind of reflux because all the blood can't go through the kidney. So the blood's rushing there and then woof, woof, right? It's going to kind of make this woof sound, and that would be your bruit. All right, so we want to check the right quadrant, the left upper quadrant, the epigastric region, and we want to definitely check over these CVA areas and listen for a bruit. They may have some peripheral edema, right? Because you're pushing, right? We did the forces of filtration for a reason. The reason that we hammered these forces of filtration is that we really want to understand the forces that drive filtration into the into the kidney, okay? So if the pressure is super high, that normal pressure into that glomerulus just went up a bunch, right? And we're losing protein. Protein causes an osmotic pressure, right? So if you've got this glomerulus, right, and you've got your flow in and your flow out, right? Well, there should be some proteins chilling here, and these create what they call an osmotic pressure. Well, that pressure pulls water and solute back. So it's a back pressure into the glomerulus. Well, when we have a ton of pressure coming here that's actually getting blunted, some of this protein can slip through, right? And that's why we have protein in the urine, because there's just so much pressure. Even though the pressure is getting decreased and the flow is decreased, still, that's what blows out these. And eventually, when these are all blown out, then in the end stages, this is all screwed up so much that these proteins slip through. And so you just end up getting a bunch of junk into your filtrate. All right, so renal artery stenosis. So how do we diagnose this? Well, the gold standard is a renal arteriogram, all right? Caution, if we use contrast in people with renal failure, we're gonna have a hard time. So MRA has kind of become one of the new things that we do because it's not gonna cause any nephrotoxic dye in the kidney. And you can also do a renal artery Doppler ultrasound. This is probably, so this is the gold standard. However, the population that we're dealing with, this is going to be pretty touchy. If their kidneys are already trashed and they don't work at all and they're like dialyzing because they're already end stage, well, then just dialyze them the next day and run a bunch of contrast. But if they still have a functional kidney and they're not dialyzing, then we want to maybe elect to do an ultrasound. So we'll talk a little bit more about those, and we'll try not to do any tricky questions on there on the test because that would just be cruel. You can also do a contrast enhanced CT with vascular reconstruction. There's a whole bunch of things, but mainly the ultrasound, the MRA, and the renal arteriogram. Just know that this is a risk, right? Because you're dumping anytime you see the word arteriogram, it means you're going to use contrast. Because the only way to light up those arteries is to put contrast through these people. And so since contrast is nephrotoxic, right? That was one of our reasons the kidneys can fail. We want to be cautious with that, particularly in this patient population. So how do we treat these people? Well, we can send them to the plumbers, and the plumbers can replumb them. So this is your urologist, right? The urologist can do an angioplasty. They can rebuild that stenotic artery, or they can roto-rooter it out. If this is unsuccessful, then you can actually bypass it. So you can bypass the entire flow. Here's your kidney, right? You try to roto-rooter this out first. If that roto-rootering doesn't work, or the angioplasty doesn't work, which would be the roto-rooting, then you can bypass it with a new afferent arterial, right? Okay, conservative measures are your ACE inhibitors. Also, calcium channel blockers are going to reduce the pressure to that. You can make them stop smoking. You can, or help them to stop smoking. You can utilize statins and aspirin. Also, what are some other adjunct medications that you can use to reduce lipids in the population? Well, you can use niacin, you can use fish oil, and you can use krill oil. So those are all options that might be helpful, but definitely you're not going to do those things when you've got this type of a problem. You need to really hit your heavy hitters. All right, so thromboembolism. So we really need to know about thromboembolism. Why? Because these people lose proteins. And when they lose proteins, then they lose their coag factors. When they lose their coag factors, they screw up their coag cascade. When they screw up their coag cascade, they have clots, okay? So they are more prone to clots for that very reason. particularly with nephrotic syndrome. Why? You gotta know. I know you know that, right? Nephrotic syndrome, because they're going to lose their coag factors. So the most often occurring cause of thromboembolism in the kidney is due to nephrotic syndrome. This is a reversible hypocoagulable state, right? Studies show that direct correlation between nephrotic syndrome and arterial and venous thromboembolism. All right, awesome. So we know that, okay? There's also IgA nephropathy can cause that. Oh, I think hypercoagulable states, right? Like neurons. Okay, so that makes sense. Why do we clot more? You better know that. All right. Thrombosis, embolism, and renal venous thrombosis. Causes, right? I just hammered that home. Also, anytime that you have a renal cell carcinoma, right? Cancer causes dysfunction in the clotting cascade. So these people are always more prone to clots and embolus. Trauma, right? If you have a bad trauma, say you fracture your femur, right? Well, you've got all this goop leaking out there. You got coag factors going nuts. Basically, it's pretty straightforward, right? Any reason that you have increased risk of clot, you have increased risk of thromboembolism to your kidney, right? So think of it like DVT. So what are the risks for DVT? Are pretty much the same risks as they are for thromboembolism to the kidney. So it's going to be, let's see, what are some risk factors? So surgery is a risk factor, right? So recent surgery, immobilization, that's a risk factor. Cancer is a risk factor. OCP use is a risk factor, okay? Pregnancy is a risk factor, okay? All of these are really good risk factors for a thrombosis. So we want to think about that. So you can say sicko, right? So remember sicko. That's some of your stuff that you can remember for that. Let's see. External compression from retroperitoneal fibrosis, aortic aneurysm, or lymphadenopathy. Okay, what the heck does that mean? Well, what that means is the kidneys sit retroperitoneal, right? So if you have some bizarre autoimmune condition that causes the retroperitoneum to become fibrotic, it's going to push against those kidneys, right? It's going to push against those vessels. It's going to increase the velocity of blood flow through the vessels and increase the risk of clot, all right? Same thing with aortic aneurysm, which I think if you've got an aortic aneurysm, you're kind of in a bad state anyways, but yes, if that aortic aneurysm hasn't burst yet, it can put pressure onto the kidneys. And then obviously if you have lymphadenopathy in the retroperitoneum, you can have pressure applied to the kidney and the renal blood supply. All right, so clinically, there's a variable presentation. Patients may range from symptomatic to asymptomatic. It depends on the acuity and how progressed the disease is. There may be some signs of malignancy. The first one to appear is hematuria. Another one's weight loss. What's the other one? Night sweats, right? They could have flank pain, gross hematuria, and occasionally they may get worked up for pulmonary embolus because they are at risk for clots. They're also at risk for a blood clot to their lung. So here's the diagnosis. What do we do? Well, we can do an ultrasound, CT angiography. Look at that, 100% sensitive. Okay, labs, we can also check their function. We can see their urine and check for proteinuria. So here's this big, huge clot. There's the little kidney bean, right? And here's this renal artery. Holy moly, there's a big clot burden right there, okay? That's not supposed to look like that. It's usually like that, okay? All right, and that's the clot. Now you can imagine that that would slow blood flow to the kidney, right? Okay, so what do we do to treat that? Well, we want to treat the underlying cause, right? We also want to give them some ACE inhibitors and ARBs so that they can decrease their aldosterone production so that they have lower blood pressure, and we want to anticoagulate. Question. Are people who are already anticoagulated at increased risk, the same risk, or higher risk than people who are not anticoagulated for a thrombosis? Answer. Anybody is at the same risk, even if they are already anticoagulated. There was a study that was performed that shows that they are less likely to have an event over time, but when they present to the emergency room or your primary care physician with symptoms that could potentially be a blood clot, they are at the same risk. So just because they're anticoagulated does not make them a candidate that they will never have a clot. So keep that in the back of your mind because that will burn you. All right, renal artery failure, acute versus chronic. Now, this is a head scratcher, okay? It's really easy, though, to think of kind of intuitively, right? An acute renal problem is something that happens acutely, right? It's an abrupt decline in their renal function. 50% decline occurring within hours, days, or weeks, all right? Why do we care? What's the difference? Well, if it's an acute renal failure, we got to treat it different than chronic, okay? The BUN may elevate rapidly, and the creatinine may take longer, okay? So they're building up all these nitrogenous products because we just break those down longer. Creatinine takes a little bit longer because it's based on how much muscle mass you have and how fast that muscle mass is breaking down. Plus, you can generally get rid of some of the creatinine because it is an extensive waste product, right? You only get rid of creatinine. So, therefore, the creatinine, if your filtration's slowly going down, you're still going to get rid of most of your creatinine until you really reach that problem state. So, although the creatinine may be normal despite marked reduction in GFR in the early stages, this is how much time it takes to accumulate in the body. So just like I was saying before, that creatinine is a complete waste product. So 100% of it is excreted, whereas the BUN is sometimes reabsorbed. The nice thing about an acute kidney injury and identifying it is this. It is usually reversible, right? That's the difference between that and chronic. So how do we approach it? Well, we want to take a good H&P, right? We want to get a family history. We want to find out if there's any renal diseases, if they have urology disease, right? Do they have kidney stones? There's some reason that all of a sudden they've got this kidney injury. Do they have hypertension? Are they on medications for CHF, and do they have diabetes? So what do I ask people? Hey, do you have any other health problems? No. Do you take any medications? Yeah, I take some blood pressure medication. And I take medication for my diabetes, okay? So that's what you got to do. You got to distill it down. You always got to ask them, you got any health problems? Nope. Take any medicines? Yep. Okay? So patients don't always get what we're trying to get at, so we got to really make sure that we ask it in a couple different ways. We need to determine if the renal failure was acute or chronic, right? So I think I talked about my mom during the last lecture. She had an acute problem. They didn't trend her labs. Since she had diabetes, they just kind of assumed that it was chronic. Well, it wasn't. It was an acute problem. She had ischemia to the kidney during surgery. That caused an acute kidney injury because there was some necrosis due to low oxygen and low blood flow for quite some time. Well, they were looking at her creatinine. Oh, she's got chronic failure. And they're just throwing nephrotoxic meds at her and just trashing her kidneys when she had an acute injury that just needed some support, some IV fluids, and she was going to get better. So we need to trend these labs. We got to do our homework. We need to get that creatinine from a year ago, from 6 months ago, from 3 months ago, from 2 months ago, from 1 month ago, so that we can watch that trend. Trends matter, right? So if the creatinine is slowly trending up or it's just staying the same, that's how we really know. The best way is that to identify lab problems, we really need to look at trends, okay? Sorry, I'm getting crazy with this pointer. Okay, we need to determine whether the AKI was due to a pre-renal an intrinsic problem or a post-renal cause. Now this usually we can elicit this in the history and physical, but we may need to do some labs to look at this also. We want to check their fluid status. Are they volume up? Are they euvolemic? Or are they volume down? Especially with CHF. So CHF can cause third spacing, meaning that the capillary beds can't handle the pressure and they leak, right? But that can also actually cause low flow to the kidney because the volume is not in the vasculature itself. So the flow to the kidney is decreased, causing ischemia at the kidney, causing an acute renal injury. We also want to think about signs of allergic reaction, right? Do they have a good history? Did they just start an antibiotic? Do they have a rash? Do they have swelling of their lips and throat? Okay, that would be an interstitial cause. Okay, do they have a suprapubic mass? Is there blood in their urine? Do they have bladder dysfunction? This suggests post-renal, right? Post-renal is a plumbing problem. Pre-renal is a plumbing problem, usually. Like you're not getting the water or blood, in this case, there. And then your intrarenal is a nephrology problem. So review your patient's medications. Some of these medications can be nephrotoxic. All right. So with acute renal failure, they came up with this cool little mnemonic. It's called the rifle classification for GFR and urinary output. So what is their risk of renal dysfunction? What was the potential injury to the kidney? Is there failure of the function? And they lost kidney function, and is it resulting in end-stage renal disease? So you can see that the GFR is going to, or the creatinine and GFR slowly increase. I think that rifle is easy enough to say. The R stands for 25%, the I 50%, F 75%, and at L you've got complete loss of function, and E is end-stage renal disease, and it's gone longer than 3 months. So 25, 50, 75, remember the mnemonic, it'll help you out. I think this is on the test, but we will review it in the future. All right, 3 categories. So pre-renal, normal kidney responding to hypoperfusion by decreasing GFR. All right, so if you've got low flow to your kidney, you're going to have a low GFR. If it's an intrinsic problem, the pathology is within the kidney itself. If it's a post-renal problem, then there's something obstructing urinary solute flow after the kidney. All right, so here's some causes. So here's the most common cause of pre-renal acute kidney injury. Low volume, okay, so they could be dehydrated. They could have a lot of diuretics on board that might cause them to still be dehydrated. Poor water intake, dehydration. Vomiting, diarrhea, burns, and hemorrhages. So think of that. Anything that decreases volume can cause a pre-renal problem, all right? Hypotension can cause it, right? Low blood flow can cause it. If they have a low circulating volume in their bloodstream, that can cause it. So congestive heart failure and cirrhosis. Medications can cause a pre-renal problem. They can constrict the afferent arteriole. Normally when we think of medications, we think of an intrinsic problem, right? But NSAIDs actually can constrict the afferent arteriole. So we need to be aware that that's a possibility. And then obviously an embolism is going to cause a pre-renal problem. So these are your big pre-renal problems. You know those, you got pre-renal basically down, okay? Then we have intrinsic problems, so tubular necrosis. These are vastly what we talked about in renal 2. So nephrotoxins, ischemia is causing acute tubular necrosis. So the tubules are having the problem. Glomerulonephritis caused by all these other problems, good pasture, sphagnose, blah, 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 right? So some sort of glomerulonephritis. What are we going to see in glomerulonephritis? Red blood cells. Red blood cells. Don't forget that. They pimp you on that for whatever reason. On every test I've ever seen, glomerulonephritis is the presence of red blood cells in the urine, and that is the take home there. Nephrotoxins can cause intrinsic problems like aminoglycosides, IV contrast, and NSAIDs. You can have vascular disease that can cause intrinsic problems like not sclerosis of the afferent arteriole, but sclerosis of the tiny arterioles within the kidney. And you can have interstitial disease like acute interstitial nephritis, systemic lupus erythematosus, or some sort of an infection can cause like a pyelonephritis. Okay, postrenal. So you can have a obstruction of the ureter. You can have BPH, right? Oh, that's the second most common cause. That's a big deal, right? You have a huge prostate, you're not getting anything at, and basically everything backs up, okay? You can have an obstruction, a neoplasm. You can have it in the cervix, in the rectum, somewhere it's obstructing flow from the urinary system. You can have obstruction from a obstruction of a solitary kidney, right? So if you only have one kidney and you're obstructed down the line, well, obviously that's still going to be a postrenal problem. Usually you wouldn't see this because the other kidney would be functioning fine. Like you've got, say, a nephrolithiasis on one side, well, the other kidney's functioning okay. So if you have a solitary kidney, though, it only takes one little stone to block you up. You could have a retroperitoneal fibrosis, which we talked about. In this case, it would be choking off the flow out of the kidney somehow, not into the kidney. So really, you could argue that this retroperitoneal fibrosis could also cause prerenal as well. So just kind of get that in your mind with that one. All right, so prerenal AKI, so you've got a decreased renal blood flow, which can be significant and can cause a significant decrease in your GFR. That is the definition. Increased level of metabolites like BUN, creatinine, and uremic compounds, right? So this is until your uremia, your azothemia, okay? Renal parenchyma at this point can be pretty much undamaged. The tubular concentrating ability is intact, so you're doing okay. Therefore, the kidney responds appropriately by conserving as much sodium and water as possible. This form of AKI is reversible when blood flow is restored. That's why I was freaking out on this doctor, because I'm like, hey man, just put some fluids into this lady and she's gonna be fine. Don't put her on a bunch of furosemide and beat the hell out of her kidneys, okay? All right. So if the hypoperfusion persists, right? So you've got this low flow state. If it persists, you're gonna end up with acute tubular necrosis. It's pretty intuitive, right? You don't have blood flow to the kidney. Pretty soon, the kidney is going to start starving for oxygen. And pretty soon, if it doesn't get oxygen, it's going to start dying. All right, so prerenal AKI. So what are some of the clinical features? Well, they're going to be fluid low, right? They're going to be dehydrated. They may have hypotension. They may be having reflux tachycardia, oliguria, right? So not any or very little urine. This is always found in prerenal problems, trying to preserve the volume. You're going to have decreased turgor pressure, right? So they're going to have that tinting when you check their turgor. Lab findings. So you're going to have an elevated BUN creatinine ratio. You're going to have a high urine osmolality, okay? So because the kidney is able to reabsorb water, okay, you're reabsorbing all your water, but there's a lot of stuff in your urine, okay? So your urine osmolality goes up. You're gonna have a decreased urine sodium because sodium is able to be reabsorbed, okay? And you're not excreting your sodium. Your body knows that you need the volume, so it's keeping the sodium. So in this state, you will decrease your urine sodium and you will have a high BUN creatinine. Now, those lab values for prerenal are almost exactly the same for postrenal because the same mechanisms are taking place to kind of keep the lab values in check. So prerenal and postrenal, it's the story. So you want to listen to the story when you're reading questions, the labs are about the same. So you don't have to memorize all three. You just need to memorize like pre-renal and look at post-renal, say, oh, actually, those are pretty much the same. And then intrarenal is totally different. So if you remember those, then you'll do fine. All right. So here we kind of look at these different causes for each of them. This is just going back to that same darn slide. I just wanted to hit you with this over and over again. So these are the causes, okay? Intrinsic renal problems, so AKA a renal pathology, right? This is a renal cause of an acute kidney injury. So glomerular filtration rate is going to go down. You're going to have decreased function of the renal tubules. Due to these damages, the kidneys are not able to concentrate the urine effectively. All right. So we already know that we're going to have a decreased urine osmolality because we cannot concentrate the urine because the tubules are damaged. All right. So clinical features is very dependent on the cause. Edema is usually present. Recovery is possible, but may take longer than a pre-renal AKI because you need to get this kidney functioning normally again. So what lab findings are we going to see? Well, we're going to see a decreased BUN and creatinine ratio. There's an elevation in BUN and creatinine, but it is less than in pre-renal and post-renal, okay? Decrease in urine osmolality, okay? You're going to have a urine osmo of less than 350, which is generally about normal. So it's less than normal due to the inability to reabsorb solute. All right, so here we go. Here's this post-renal, right? So renal failure. Now we're moving on to post-renal. So urethral obstruction, nephrolithiasis, obstruction neoplasm, solitary kidney obstruction, and retroperitoneal fibrosis. Here's the lab values. So look at this. Pre-renal, right? High BUN creatinine ratio. Really, this is 10 to 20, whatever. Just remember, it's about 20 to 1. This is less than 20 to 1. So 20 to 1, 20 to 1. Okay, specific gravity high, specific gravity pretty high. Okay, in late, you're going to have it low because you're just not getting out. So that makes it a little difficult. But you really can't hang your hat on specific gravity for any of these except pre-renal, right? So in pre-renal, you've got a lot of junk that's making its way into the kidney due to the pre-renal obstruction and what's causing you to increase the specific gravity, okay? Urine osmolality is increased from that same reason. In intrinsic, remember, you cannot reabsorb or concentrate the urine. So the urine has a lot of water in it, okay? So if there's a lot of water, then there's not a lot of stuff. And that's what osmolality measures, the amount of stuff in the urine. So with a pre-renal problem, it's very concentrated. You're not making a lot of urine, but it's concentrated. And you've got a lot of stuff. Same thing with post-renal, okay? Urine sodium. So in pre-renal, the urine sodium, it seems counterintuitive, but the thing is that the urine sodium is being saved. The kidney can still function. It's saving sodium. Why? Because this needs to be considered a low volume state. Okay, you're at a low volume state, so you're going to save your sodium because your body is smarter than you are. Okay, your body wants to save the sodium, reabsorb water to continue to keep your blood pressure up. Same thing with post-renal, okay? Don't worry about this early, late, whatever. If you can get this down, you'll be doing better than most, okay? So in early or in post-renals, don't look at that. In post-renal, it's going to be less than 20. So remember I said 20 is about your hallmark for urine sodium. So urine sodium, less than 20 with pre-renal, less than 20 with post-renal, greater than 40 with intrinsic renal. Fractional excretion of sodium. Fractional excretion of sodium is usually about less than 1%. So In pre-renal, it's less than 1%. That's pretty much normal. In post-renal, it's less than 1%. That's pretty much normal. In intrinsic renal, you're getting rid of a lot of sodium. Remember, the body wants to reabsorb sodium. So when you can't, when the tubule is affected, which we did those drawings, we can't reabsorb sodium, so sodium's going to spill into the urine. Okay, and then this creatinine to protein ratio, right? So you've got a lot of creatinine for protein because you're spilling it, and you've got a lot of schmutz in your urine, right? You're losing protein because that filtration is screwed up. Here you lose it also. Here you don't, okay? Don't lose it. Now, the real take home is here you've got some hyaline cast. Here you've got some granular cast, all right? Epithelial cast. These are buzzwords, right? This is like, if somebody gives me this, I'm like, thank you, epithelial cast. Why? Because the epithelium is being shedded. Your kidney is dying and the epithelial cells that line that tubule are shedding off. That's why I made you do that thing with the cells, so that you realize that this brush border is being shed into your urine. Now you can see it. That's what granular casts are made up of, squamous cells and brush border cells and all that kind of stuff. Here you might see some red cells, right? If you've got a stone, you might see some crystals because they're, maybe that's what's causing the stone formation, right? Maybe an infectious process, so there might be some white blood cells. Here you're gonna get, this is not really very high yield, but you might get some hyaline cast, right, with the pre-renal. But the money shot's right here, okay? And then remember, with glomerular nephritis, red blood cells. I repeat, glomerular nephritis, red blood cells. Okay, so this is just kind of a little bit of review here, right? So see how we're reabsorbing sodium into our bloodstream, okay? And then we're also reabsorbing sodium into the urine, okay? So we want to make sure that we understand how this kind of flow goes. And I think actually the one that we did was a lot better. So go back to your drawings and just realize that sodium is not able to be reabsorbed when the tubule's damaged. That's why you have a high fractional excretion of sodium when you have an interstitial problem. So let's go back. So see that? Oh my gosh, this makes sense, right? So high fractional excretion of sodium. Why? Oh yeah, now I remember, because this thing wasn't working. So you can't absorb sodium back. So the sodium stays here when you have an intrinsic problem and you're gonna pee it out, okay? And then some smart suckers learn that this tells you what kind of damage you have. Smarter than me. Okay, post-renal. Now this is pretty quick. So it can be from an obstruction caused by a bad urinary tract infection. It can be caused by some sort of blockage. It can increase the tubular pressure and the inability to excrete urine. It can lead to a decreased GFR if everything backs up and backs up and backs up and backs up behind our blockage here, okay? However, the blood supply to the renal parenchyma is intact, so that's good to know. Should note that both kidneys need to be obstructed to increase the creatinine level, right? So if we have one functional kidney, life is good. That's why they talk about that solitary kidney with an obstruction that is post-renal. If the obstruction is not relieved, then it can lead to acute tubular necrosis. So that's where some of those say, like early on, oh yeah, your sodium's pretty normal, but later it goes wacky. That's because as you continue to back up and back up and back up, and all these inflammatory compounds are in the kidney, well, the kidney can necrose. So how does this present? Well, if it's a stone, they're going to present like they're jumping all over the bed, and they're going to be in a lot of discomfort. They can have a fever if there's an infectious process. There can be nausea, vomiting, frequency, nocturia, urinary retention. There can be some tenderness over the suprapubic region, right? Laboratory findings, we might see presence of white blood cells. Bacteriuria is really kind of like a normal finding, so don't like hang your hat on that ever. If it's pre-renal, you're going to see hyaline cast. If it's glomerular, this is the money shot, guys. Glomerular damage. They like that one for some reason. White blood cells are going to suggest some kind of inflammatory process. I wouldn't hang my hat on any of that. And then fatty casts are going to be seen in nephrotic syndrome. A renal ultrasound can show hydronephrosis. Well, what the heck is hydronephrosis? Well, the kidney is in this fixed sheath, right? We went over this in anatomy. If you've got backup because you're not able to get urine out of the ureter, right? And the flow backs up into this kidney, well, it's in this fixed space, but the space can extend a little bit, okay? And that's called hydronephrosis, and it hurts like heck because you're really in this fixed space, but you have too much fluid in there, and so the kidney enlarges. Well, that can be seen on a CT or urography. You can assess the renal function and locate the obstruction with this CT urography. That means you put contrast in, and then it's like, ooh, the contrast stopped at this obstruction. What the heck? Well, it's because there's an obstruction. All right, so how do we treat acute renal failure? Well, if it's pre-renal, we want to give them IV fluids. If they have ascites or edema, we want to watch out for the normal saline. And we definitely want to discontinue nephrotoxic medication. So I think we talked about my mom, right? Well, we got to take care of our parents, dude. That's why we do what we do, to take care of the people we love. But the take home here is that dude changed his entire treatment plan after I slammed him, right? Why? Because he was loading her with nephrotoxic stuff. Then he was like, oh yeah, I guess I shouldn't do that. I don't want to kill her kidneys. That's a good idea. So you discontinue nephrotoxic medications. What about intrinsic? Well, same, discontinue nephrotoxic medications. If acute tubular necrosis develops, then we want to treat it like acute tubular necrosis, and we want to basically be supportive for them. If it's post-renal, we have to get the plumber involved, right? Call Mario. Mario and Luigi will take care of that, okay? All right. So what are some complications? Well, you can have expansion of your extracellular fluid. This can cause edema in the lower extremities. We're most worried about when it gets into your pulmonary system, which you'll hear crackles on physical exam. There can be some metabolic processes like hyperkalemia, metabolic acidosis, hypocalcemia, hyponatremia, hyperphosphatemia, and hyperuricemia. Woo, that's a lot of hypers and hypos. Okay, they can have uremia, and they're at increased risk of infection, right? Okay, so although the prognosis varies widely, the severity of renal failure and other comorbidities will depend on their outcome. Generally, about 80% of patients will fully recover. My mother fully recovered. The older the patient is and the severity of the insult plays a role, right? If you've got an old sick patient and they just had an AKI, they could be in deep trouble. Most common cause of death is infection. Then they have cardiorespiratory complications, and that is about 75% of all deaths are caused by that. Whew. All right, going on to chronic renal failure, chronic kidney disease. So chronic renal failure is defined by a GFR of less than 60 or the presence of kidney damage for greater than 3 months. You should know this definition, okay? Classified according to estimated GFR stages 1 through 5. You need to know this also. So you need to know how that GFR, and get yourself a little mnemonic or whatever you do for your brain to remember what these stages are. Generally, patients are asymptomatic until stage 3. We really care about stage 3 because at stage 3, they have a chance to reverse this. Stage 4 and 5, they're in the toilet. They're headed toward dialysis. There's no turning back. All right, so memorize this, okay? Don't often say that because I don't want to make you do stuff that you don't have to. Memorize this, okay? So don't memorize every little portion, but just know, like, oh, a normal kidney is about greater than 90 GFR. A little bit of kidney damage, greater than 60, between 60 and 90, right? At stage 3, we've got 3A and 3B, right? So between I would say, yeah, 50, that's 45 is weird, but so about 50 to 60, that's stage 3A, and then 30 to 50 is stage B. Now, once they get past this, 15 to 30, you're at stage 4, and then at stage 5, you're dialyzing this patient because their kidneys just are not functioning. So what are some chronic renal signs, right? Signs of anemia. So chronic renal failure, you can have anemia. It's kind of like anemia from decreased EPO production. It's really tough to identify between that and anemia of chronic disease. They're both a normocytic anemia. So you want to, basically, if they have impaired kidney function, it kind of lets you know. But there's going to be some signs of anemia, fatigue, impaired cognitive ability, immune function, cardiovascular disease, heart failure. That would be a new or increased heart failure. They're going to have poor handling of sodium and water. That's stage 5, peripheral edema, pulmonary edema, hypertension. These are indications to dialyze a patient, right? Also, uremia is a indication. They can have metabolic acidosis. So remember, hydrogen should be secreted out into the urine in that tubule. If the kidney is just not functioning at all, well, what the heck? They're going to keep all their hydrogen so they can have increased hydrogen ions, which can cause metabolic acidosis. Here's another beautiful part of end-stage renal disease. They can get pericarditis. Why? Because they're uremic. They can also have platelet dysfunction. Why? Because they're uremic. They can have peripheral neuropathy due to these toxic compounds that are causing their small little blood vessels to be damaged in the small little nerves, and they can have restless leg syndrome. So all sounds really fun. All right, so chronic kidney disease. Diabetes is the most common cause, about 30% of cases. Then we got hypertension. Glomerular nephritis that's chronic can account for 15%. Interstitial nephritis, polycystic kidney disease, obstructive uropathy, many other different causes from AKI can go to chronic kidney disease. Chronic kidney disease is more common in African American patients, right? So for whatever reason, they definitely have more muscle mass, so they secrete more creatinine. So we should do some reading on this and actually see why. I think I probably have, and I don't really remember if there was a clear indication of why, other than just the pure genetics of the situation. All right, so chronic kidney disease. So the creatinine clearance is the most common clinical measurement of the glomerular filtration rate. So they use creatinine clearance to calculate GFR, and it's an estimated, so they call it an eGFR because they actually estimate the glomerular filtration rate. So if the creatinine is low, the GFR is high, the kidneys are functioning, right? That's the way we want them to work. Get rid of the creatinine. That means the creatinine is low in the blood, right? And the GFR is high. That's a good thing. An increase in plasma creatinine is an indicator of disease progression. So we need to trim these labs, right? All right. So chronic kidney disease presentation. So hypertension, second to sodium and water retention. That's why we use either direct aldosterone inhibitors or ACEs and ARBs. CHF can cause it. Fluid overload can cause it. Hypertension and anemia would be present with CHF. Pericarditis can be caused by uremia. So this is a terrible slide. All right, so GI complications, I suppose I'll just read it to you because these don't come up very well. GI causes are usually due to uremia, right? So uremia is going to cause changes in the way that we secrete things also can cause GI bleeding, can cause nausea, vomiting, and anorexia. Neurocauses are lethargy, somnolence, confusion, peripheral neuropathy, and uremic seizures. They can be weak. They can have hyperreflexia from the calcium. They can have restless legs, and the pain is only relieved by movement. Hematologically, they can have a normocytic, normochromic anemia secondary to EPO deficiency. They can have bleeding due to platelet dysfunction and secondary to this uremia, because uremia causes the platelets not to function. That's the same reason that they have infection, because the white blood cells cannot degranulate. All right, so chronic kidney disease presentation, fluid and electrolyte problems. So they have fluid overload. This can cause edema, which is particularly worrisome if it's pulmonary edema. They can have hyperkalemia because they are unable to excrete their urinary potassium. Hypermagnesium, same thing. Hyperphosphatemia, found as they are unable to kick this stuff out. And metabolic acidosis, because they're not excreting hydrogen ions. So how do we diagnose this? Well, the gold standard here. So we want to do, we're going to look at the glomerular filtration rate, which is really the diagnostic criteria here. We'll also look at the CBC, CMP, urine microalbumin, serum cystatin C, yeah, I use that one a lot, and renal ultrasound. So basically CBC looks for anemia. The CMP is going to look at the BUN, creatinine, their electrolytes, and their albumin. The urine microalbumin is going to assess for the level of kidney damage. The serum cystatin C is going to be something that's pretty much used by nephrology, as I have never ordered that test. The renal ultrasound is to assess for any obstruction, and you want to evaluate the size of the kidneys as well. Okay, so CKD treatment, we need to modify their lifestyle. We want to refer them to a dietitian. They need to go on a low protein diet. They need to restrict their salt. They need to restrict potassium, phosphate, and magnesium. They need to have really good glycemic control, and they need to stop smoking. Medications, well, we can do blood pressure control. That's going to be ACE inhibitors. We want to slow their progression to end-stage renal disease and help with their proteinuria by decreasing the pressure in the kidney. We want to use caution with our ACE inhibitors because they can help lead to hyperkalemia. Other hypertensive medications may also be used, and if they are having hypokalemia, we could use what? A direct aldosterone inhibitor, which would be spironolactone. Okay, treatment. So correct any electrolyte abnormalities. Deal with the hyperphosphate by using calcium citrate, which is a phosphate binder. Treat this along with calcium and vitamin D secondary to hyperparathyroid and uric osteodystrophy. Treat the anemia with erythropoietin. Other issues, they may have pulmonary edema that's not responsive to diuresis. In this case, we need to dialyze this patient. Dialysis, if completed, if they're in complete renal failure, and then transplant is the only cure. Renal cell carcinoma, aka hypernephромia or renal adenocarcinoma. So renal cell carcinoma accounts for 90 to 95% of neoplasms arising from the kidney. Annually in the US, there's about 13,000 deaths with 58,000 cases. The male to female ratio is greater for males, 2 to 1, usually between the ages of 50 and 70. Renal cell carcinoma risk factors include smoking, acquired cystic kidney disease like polycystic kidney disease, or kidney disease associated with end-stage renal disease, tuberous sclerosis, familial papillary renal cell carcinoma, or this VHL, which is an autosomal dominant disorder. I'm going to try to pronounce this, von Hippel-Lindau disease. I've never said that before. This may cause patients to develop renal cell carcinoma. So clinically, 20 to 30% are asymptomatic. We may catch this by decreased GFR, and this may be an indication for ultrasound. They can have some hematuria. They can have some flank or abdominal pain. There may be a palpable mass. If you do a good retroperitoneal exam, they may have symptoms of cancer like night sweats, weight loss, fever, malaise, frequent occurrence. This is a frequently occurring in paraneoplastic syndromes. So differential diagnoses are going to be your renal cysts, benign renal neoplasm, inflammatory lesions, or other malignancies that involve the kidney. Cancer of the renal pelvis, sarcoma, lymphoma, and Wilms tumor. Renal cell carcinoma, on physical exam, you may have a palpable mass. They may have hypertension, and you may note a varicocele on the left side due to the destruction of the testicular vein. So people with varicoceles on the left side, that renal cell carcinoma causes blood to be pooled down in the testicle, causing the testicles to enlarge as far as the vascular supply goes, and can cause an increase in likelihood of varicocele. But a lot of people have a benign varicocele on the left-hand side with no signs of renal carcinoma. All right, labs. So we want to look for hematuria. We may see that gross or microscopically. We're going to look for their electrolytes like hypercalcinemia. As noted with Joel's lecture, I want to belabor this point. If somebody presents with symptoms secondary to hypercalcemia, we need to first fluid resuscitate this patient and then use furosemide to diurese. Let me repeat that. If someone presents with symptomatic hypercalcemia, first we want to fluid resuscitate, and then we want to diurese with furosemide. Tip, I don't usually report things twice, so you might want to take note of that. All right, CBC, you're going to see erythrocytosis in 3% of patients, and you may also see anemia in advanced disease. Renal ultrasound is going to detect that mass. You can also do a CT with or without contrast. The optimal study would be with contrast. Renal cell carcinoma treatment, the standard is radical nephrectomy. So we just need to take this kidney out. There's also some interferon treatments and radiation. All right, so there's the references for this. I expect you guys to know this forwards, backwards, and sideways. You'll be well prepared for this exam. You guys better rock it. I have a goal that everyone passes renal the first time, and I'm going to stick with that. Congratulations. You have completed renal 3, and I have. I'm tired.